Thank you very much, Charlotte, and welcome everyone. I'll try and keep to time, and I'll try and give you time for questions and a discussion at the end. This presentation is in two halves. I've got, first of all, imaging the Achilles tendon, and then I've got a second one on hindfoot, ankle and hindfoot. So the two of them together make up the whole session today. So without further ado, first of all, we're going to have a little contract between us, if that's all right. I give you teaching and this lecture, and you please I said, give feedback, please. I need that for my appraisal GMC validation. So I really, really would be grateful if at the end you could put some comments into the chat so that we can collate those as feedback. And perhaps these are the bits. I'll put a reminder slide on the end, but was the lecture clear? Was it well presented? Was it relevant? What are the areas for improvement? And then perhaps a score between 1 and 10. 1 is poor, 10 is excellent for the overall session. And any free text comments would be welcome. So moving on. So this talk on the Achilles tendon, I'm going to try and cover the anatomy and then the conditions of peritendinitis and paratendinitis with some examples and explain the differences. Touch on retrocalcaneal bursitis, touch on tendinosis of the tendon and tendon tears. So first of all, just some anatomy revision. So the Achilles tendon is formed from a fusion of the gastrocnemius and the soleus muscles aponeuroses, as you see in this diagram on the side on the right. That forms the Achilles tendon, which inserts on the calcaneum. There's no synovial sheath for this tendon, but it has something called a paratenon, a layer of connective tissue. The blood supply is from a network of arteries in the paratenon. The mid and the distal tendon have reduced blood supply, and that's why the distal 3 to 6 centimeters are prone to rupture. The tendon will be low signal on all MR sequences, just as all tendons and ligaments should be low signal on all MR sequences. If you do a cross-sectional image, you will see a concave anterior surface, and the average AP diameter or thickness of the tendon should be 6 millimeters. There is a retrocalcaneal bursa. I'll show you that in a diagram in a minute. That should be very thin. It has a sliver of fluid, only 1 millimeter AP diameter. And in front of the tendon, between the tendon itself and the tibia and fibula, the space is filled by a fat pad called Kager's fat pad. So moving on to peritendinitis. So what is peritendinitis? How does it look? What does it look like on the MRI? Here's a 3 axial images. You can see the concave anterior surface. That means it's a normal shape. And on all 3, so this is high, mid, and distal tendon. And you can see this on the fat suppressed sequence, a very thin high signal around the tendon itself. And that's indicating that this patient has peritendinitis. Peritendinitis is activity related, injuries, altered biomechanics, overuse in athletes. That's who gets this. That's who get this condition. And paratendinitis is inflammation in either the Kager's fat pad or the retro-Achilles fat pad between the Achilles and the skin. So basically, it's fat pad inflammation. And just by the way, these 2 images do show some interstitial splits in the tendon as well, these little high signal areas, because it should be uniformly black. And there's a small split here in the anterior surface of the tendon. This is a proton density fat suppressed image, and this is a T1 weighted image on the left. Sorry, T2 image on the left. Then tendinosis. So this is showing mid-substance tendinosis. So we talk about the Achilles tendon as a proximal or muscle tendon junction, a distal or insertional tendon, and then the mid-Achilles tendon. And you can see here in a longitudinal image, the sagittal image, that there is increased AP diameter of the tendon. It's fusiform in shape rather than being straight. So this is mid-substance tendinosis. It's degenerative in etiology due to aging. It's non-inflammatory. So the causes could be hypoxic, where you may get episodic symptoms. It can be mucoid, where it is usually silent, you get no symptoms. You can get calcific tendinopathy, so you will see calcification within, or fatty degeneration. And what will you see? You'll see tendon thickening, loss of the anterior concavity on the axial image. Remember those images I was showing you had a little concavity at the front. This one doesn't, it's convex. The signal will be normal. It should be still dark, and there may be peritendinitis. There may be a little sliver of high signal around the outside. You can get Achilles enlargement, and there are various conditions that cause this. Rheumatoid arthritis, gout, xanthomatosis or lipomatosis. Sorry, got a spelling mistake there. All of these can cause enlargement of the Achilles tendon. And here's some examples. This is a massively enlarged tendon in the axial and sagittal planes. Although I'm not trying to cover ultrasound or treatment in any great degree, ultrasound also is very useful for the Achilles tendon. It can be assessed pretty well with ultrasound. The advantage with ultrasound is that you can use the color Doppler function to assess blood flow, neovascularity into the tendon. So inflammatory conditions can cause neovascularity. It's the growth of new vessels into the tendon, which when you switch on the color, will show you this color. And this is all abnormal. Normally, tendons have no visible blood vessels, no visible color into the tendon itself. So this is telling us there's neovascularity. And I just wanted to show you an example of one particular image-guided treatment that has been tried. As with a lot of other treatment modalities for Achilles tendinopathy, the evidence in proper trials is limited, but it has been used, and certainly short and medium-term resolution of symptoms or improvement of symptoms has been reported. So this is high-volume image-guided injection. So this is an axial image. Here's a needle that's been placed under ultrasound guidance just behind the anterior surface of the tendon. The skin is up here. This is the anterior surface. So the needle's gone in just anterior to the tendon between that and the fat pad. So here's a diagram of where it's gone. And what is done is you inject very high volumes of fluid. So it could be normal saline, could be a combination of normal saline, steroid, and local anesthetic, or it could be just a combination of normal saline and local anesthetic. And up to 50 mils can be injected. So high volume injection is normally 30 to 50 mils. And what happens immediately afterwards is here's a post-injection image, and all that color flow that you saw on that first image I show you has been effaced, has gone. It's not there anymore because the treatment is supposedly said to disrupt the neovascularity, the new blood vessels, feeding increased blood flow into the tendon, and also the nerves which grow into the tendon, which may be giving rise to the symptoms. So certainly short and medium-term results seem good. Patients seem to improve their symptoms. And you do this as a minimally invasive procedure when clinical conservative treatment is not helping, is not working. Moving on to tears of the Achilles tendon. So here we've got that increased AP diameter. It's a fusiform shaped tendon. There is some increased signal within. So it's gray rather than black in the center on this T1 weighted image. Here's a fat suppressed image, and you can see this fluid split in the middle. So that's a central tear. It's not reaching the surfaces. And here's the actual image showing you that central tear, loss of the anterior concavity of the tendon. So that's an interstitial tear. It's an intrasubstance tear. Here's an example of an insertional tendinopathy. So it's where it inserts onto the calcaneum. There's markedly increased AP diameter. There's also some ossification within the tendon there. And there's a Haglund's deformity, or a very prominent posterior superior corner of the calcaneum. So this occurs in overuse. The prevalence is 18% in runners and 9% in dancers. So it's pretty common. Haglund's deformity I've mentioned. It can occur in inflammatory arthropathies. It's a higher risk in patients who are taking corticosteroids or diabetics, hypertension, obesity, gout, and in certain antibiotics. The fluoroquinolone group of antibiotics can cause this condition. I've already mentioned Haglund's deformity is a prominent posterior superior corner of the calcaneus, and this may be a mechanical cause, perhaps repeated subclinical trauma to the tendon, giving rise to tendinosis. The retrocalcaneal bursa should sit here in between the bony calcaneum and the Achilles tendon, just at the insertion. And normal bursa should be no more than 1 millimeter AP diameter. This obviously is much more than 1 millimeter. It's probably 5-6 millimeters here. It's common in uphill runners. It's predisposed to by hindfoot varus deformity or a rigid first ray. If you see it as a bilateral condition, you should suspect a systemic cause such as rheumatoid arthritis. So how do we define it? Anything more than 2 millimeters AP diameter is a retrocalcaneal bursitis, and you need to see the surrounding inflammation. So you've got some increased signal here in the fat pad as well. An Achilles tendon tears, there's a bimodal age distribution, so they occur in 25 to 40-year-olds, and the second group is over 60-year-olds. And the underlying tendon is rarely normal in patients with a tear. So it's probably had some chronic tendinopathy, and then the weakened tendon tears. So the risk factors are degeneration, inflammatory conditions, previous contralateral tendon repair, so the other side, patients on fluoroquinolones, patient on steroids, and if there's a Haglund's deformity. And the typical story is you've got a weekend warrior, somebody who's not been very sporty, very active for a long time, maybe was in their younger days, who decides suddenly they're going to go out and play squash or tennis or something which has explosive turning, running forward, etc. And they get a sudden pop on pushing off from dorsiflexion. In the USA, basketball, tennis, football are the commonest causes. It occurs in older patients at sites of tendon degeneration. And Achilles tendon tears can occur anywhere along the length of the tendon. Acute tears will be shown as high signal fluid in the tear, and then peritendon hemorrhage and edema. So here's the tear in this mid Achilles tendon, but you can see the Achilles tendon was not normal. It was thickened, and there's degenerative increased signal here where the tear has occurred. In older tears, you get granulation and eventually scar tissue. So it never heals back to its normal state. It's never as strong as it previously was, and on MRI, it never returns to completely normal previous appearance. In a chronic tear, there will be retraction of the torn ends away from each other, and it may be actually difficult to find the tendon edges. It will give rise to muscle wasting proximally, and you may get fatty degeneration of the muscles. So the radiologist report needs to talk about how wide is the gap, the quality of the underlying tendon, the cross-sectional involvement. For example, here there's quite a high cross-sectional involvement, whereas it may not always be, and whether or not there's muscle atrophy. Here's a subacute tear. I think by that we mean that the underlying tendon is abnormal, and it's a fairly recent tear within that. So it's very bright fluid signal, and there's inflammatory change around it. And here's a distal tendon tear on this one with a large gap. and there's a tiny stub of normal tendon still attached to the Achilles. This is a mid Achilles tear, a shorter gap, but a complete tear. There's fluid going all the way across. Okay, so I'll move on now to the second part. Are there any questions in the meantime while I'm just firing that up?
Nothing in the chat so far.
Okay, please feel free to put questions in. Remember, no question is silly or stupid or anything like that. All questions are good, and the more interactive we make this, the better. Although, unfortunately, with online, it's quite hard to do interruptions and things like that. Okay, so moving on to ankle and foot. I'm just going to cover some basics of anatomy and then show you some example cases as well. This is a talk that talks about systematic assessment of the hindfoot and ankle. So I'll touch on which structures we are assessing, give you examples of normal anatomy and pathology, and I'll include some comments on indications and alternative imaging if appropriate. And then we'll move on to questions. Sorry, I haven't actually got any quiz cases, I don't think, today. And I'm not sure, I certainly would like feedback. I'm not sure whether Charlotte is planning CPD certificates, but she'll tell you, I'm sure. Okay, so the structures to be assessed. So we've got, we look at alignment. We look at whether there's any fluid, whether it's abnormal, whether there's too much. We look at the medial and lateral malleoli. We look at the tendons around the ankle joint. We look at the ligaments of the ankle joint, collateral ligaments. We look at the structures posterior to the ankle and the posterior part of the ankle joint, anterior structures. We look at the joints, so ankle joints, subtalar joints, other midfoot bones and joints. We look at the bone.
Umesh, sorry,
Yeah.
we've still got your old screen. We've got your Achilles tendon screen.
Sorry. Okay, hold on. I haven't shared properly.
No worries.
Let's go to that. I apologize. Okay, so ankle and foot. Okay. Right, so that's a sort of list of structures we're going to look at: bones, muscles, nerves, tarsal tunnel, sinus, tarsi, and vessels. So hopefully I'll be able to cover all that. Okay, looking at alignment. So what do we mean by alignment? Well, there's a few things we need to look at. So first of all, looking at whether we've got a flat foot or a pes cavus. So on plain radiographs, and they have to be weight bearing, that's the best way to assess flat foot or pes cavus, but we can get an indication on MRI because although the patients are not weight bearing, they are positioned so that the foot should be at 90 degrees to the lower leg. So if they've been properly positioned, if they can assume that position, then we do get some clues as to whether we've got anything like that. So the talar declination angle, that if you draw a straight line through the long axis of the talus, it should go through the first metatarsal on a lateral weight-bearing radiograph. And that angle should be, a normal should be about 21 degrees. A steep angle, meaning it's flatter, the talus is, steep angle is when the talus is more inclined. So that angle increases. I've got an example I'll show you in a minute. You get in pes planus or flat foot, and a shallow angle you get in pes cavus. So some examples. Here's a flat foot. So if you drew a straight line through this talus, it's not going through the first metatarsal, and that's a flat foot. You can actually see how flat it looks. The longitudinal arch is gone on this lateral weight-bearing radiograph. And here's a severe pes cavus. And here the talus is pretty horizontal. So the angle between the horizontal and the talus long axis is zero, basically. So that's a shallow declination angle or a pes cavus. And you can get a clue to that on MRI, although it's not the proper way, the reliable way to assess it. The other other alignment we should look at is whether we've got hindfoot valgus or varus. We do that on a coronal view, and it's done by drawing a straight line through the long axis of the tibia and assessing the medial border of the calcaneum to that long axis and what's the angle between them. Normal is about 6 degrees. Here's an abnormal example, and in this particular example is 22 degrees, that angle. So mild valgus is 7 to 16 degrees, moderate 17 to 26, and severe is 20, more than 26. And what happens in this condition is that the outer part, the lateral part of the calcaneum here impinges on the lateral malleolus, and you'll see bone bruising in that area. You may see edema in the soft tissues around. That's external impingement due to hindfoot valgus. You can also get talocalcaneal impingement. So you look at it on a sagittal view. So the talus lateral aspect will impinge on the angle of Gissane of the calcaneus, and you're just about seeing a little bone marrow edema there. And this again will give you calcaneofibular impingement. But this you see quite often earlier than you actually see the more severe example I showed you on the previous slide. So it's a clue as to on MRI as to why the patient may be getting pain.
Umesh, can we do a couple of questions while we're going
Yeah,
along?
yeah.
So we had one. Oh, we've had quite a few. So Rosalind said, is it possible to give therapists a percentage likelihood of a tendon rupture on basis of the tendon paratendon pathology?
In the Achilles, I think we're talking about.
Yes, sorry, we're going back. Yeah.
I don't think so. I mean, if it's a very, very abnormal looking tendon, I'm not sure I can give you a percentage risk because it all depends on the patient activity, doesn't it? I mean, if they've got severe tendinopathy and they've stopped doing all their sports, then the risk is much lower. So no, the answer is, I'm sorry, I don't think I can give you a risk.
Okay. And we also have this is Bonza. Is there an observed or reported link between plantar fasciitis and BP meds statins or any link between tendinitis and COVID vaccinations?
I don't know of any link between COVID vaccinations and tendinitis. I mean, obviously, cases have been reported where the injection, where the vaccine has been actually, anatomically stuck in the wrong place. So we have seen it in shoulders and things like that. We've also seen lymph nodes enlarge. So if, for example, a patient turns up for an MRI shoulder in a short period after a COVID vaccine, we can see lymph nodes, but obviously that's just a normal reaction. Sorry, what was the others? Hypertension treatment. I have a feeling there is, I'm not a physician, there are some antihypertensive treatments which cause tendon pain. I'm not sure that whether they cause actual anatomical changes. I haven't seen that reported. And the third one was?
We've got a few. So, Ian, I might need you to unmute yourself and just give us a bit of context about what we were looking at the time. But Ian said, would there be any benefit to MRI scan, post-surgical repair or conservative management? Question mark, patient confidence, question mark. But I don't know what he was relating to at that moment.
Yeah, okay. I think, I mean, what's being asked is, can the MRI tell us, oh yeah, healing's pretty good, there, don't worry, it's all going well. Well, I mean, certainly MRI will tell you after repair that there's no gap. It'll never look a normal black signal, but we don't expect that to happen. I guess what the other thing is, if there's no peritendinous inflammation, so if you're not seeing any high signal in the fat pad or any severe in the paratenon, any severe changes, then all of that is good news. But I think you will still see some increased signal, not fluid, but some increased signal, and you will still see thickening of the tendon post-repair. Obviously, the other one is you might worry, is there a recurrent tear? Now that it'll be very useful for. So if you suspect a recurrent tear, then yes, it'll be very useful.
Okay, and we'll do a couple more and then we'll move on. So Danny has asked, does Achilles tendinopathy in an RA patient tend to improve well with RA medication, or is a more comprehensive approach with rehab, etc., recommended?
Very good question. I'm not a treatment specialist, so I think that's one for you guys. uh, sorry, I just don't know. That's not my it's not my expertise.
Fair enough. And Janet has asked, does plantaris lead to the into the Achilles tendon?
Yes, it does. Yeah, yeah. Sorry, that little anatomical detail I didn't include. But yes, it'll fuse on, and it's part of. So it's not just soleus and gastrocnemius. Plantaris also sends a little contribution to the Achilles. Yes.
Thank you, as you were.
Okay. So carrying on with ankle and foot and fluids. We look at where there might be some fluid. Is it normal? Is it abnormal? I've got a couple of examples here where there's a great bulge out here at the back on sagittal images. I think the one on the right is a gradient image T2, and this is a spin echo T2. What we're seeing, not only some fluid, so this white stuff is fluid, and it's sort of almost encapsulated here at the back, but there's also some dark stuff in it, and it looks much darker, if you will just take my word for it, with it on the gradient T2 image. So that's called blooming. So on gradient images, if you see something dark and it looks worse on the gradient image compared to the standard T2 image, that's called blooming. And blooming artifact happens when you've got some metal there. So what this is saying is there's fluid here with some dark stuff in the middle and blooming artifact. So that is telling us there's hemoglobin degradation products. So actually there's been some bleeding into this joint. And part of this fluid may be altered blood or it's synovial fluid, but there's been bleeding into it. So you might see this appearance in conditions such as PVNS, pigmented villonodular synovitis, or trauma, or something along those lines. But MRI is actually pretty good at telling us when there's been bleeding. Here's another retrocalcaneal bursitis. There's much more than 1 millimeter AP diameter of fluid here, and there's some gray stuff in it. So there's some debris, some synovitis perhaps in it. And then down here is the insertion of the plantar fascia, that dark structure there, on the calcaneum, and there's bone marrow edema at that insertion site. So we have also got plantar fasciitis. And don't forget that anatomically, functionally, the Achilles and the plantar fascia are regarded as one continuous unit. And in embryology, that's what is the embryological basis of saying that. Okay, so moving on to assessment of the tendons. So once again, another example of plantar fasciitis with a coronal image as well. So it's the medial bundle is the most commonly affected. You get tendon thickening of the fascia, increased signal within, and you may see fluid around it. You can get splits within it, so you will see fluid much more easily, much more prominently. And you can actually get complete tears, although that's very rare. And there's inflammatory change around, so there's increased fluid all around, including in the bone. So here's an axial image. I find I rely on the axial images first. I look at those first to look at the tendons around the ankle joint. Obviously, on the medial side, you've got Tom, Dick, and Harry, tibialis posterior, flexor digitorum longus, and flexor hallucis longus tendons. So the Dick and Harry here are nice and normal and small and thin and completely black. But Tom here is thickened, he's enlarged, And when you look at it on the sagittal image, there's high signal, very obvious in the middle. And you almost wonder here whether that high signal is going through the posterior surface of the tendon. So that could be either it's severe tendinopathy, or actually there may actually be a longitudinal split tear within that tendon. So that's an abnormal tibialis posterior. And the peroneal tendons are here just behind the lateral malleolus. And then in the extensor tendons, there's one of them shown clearly, probably another one there, perhaps another one there. So the extensor tendons at the front. So I always look at it on the axial first, and then I may look at it on the sagittal and the coronal if I want to confirm what I'm seeing. Obviously, in tibialis posterior dysfunction or tendinopathy, you may get an os navicularis, so that's an accessory navicular bone next to the navicular, and you may see high signal in the tendon associated with this. That's called the os navicularis syndrome, and the presence of the os predisposes to tibialis posterior tendinopathy here at its navicular insertion. And the quadrilateral capsule stuck on the skin here is telling us that's what the patient's complaining of, that's where the symptoms are. Okay, so moving on to assessment of the ligaments around the ankle joint. So looking at the lateral side, first of all, I mean, you on MRI, we should see the anterior and the posterior tibiofibular ligaments quite well. And these little slips of the talar fibula, anterior and posterior ligaments sort of merge with the other, and then the calcaneofibular ligament you should see underneath the peroneal tendons as they go past. So let's show you those. Oh, actually, and then this is I didn't have a diagram, but just above that level, at the distal tibiofibular synchondrosis, you should be able to see the anterior and the posterior distal tibiofibular ligaments. And as I said before, ligaments are always dark, always black on all MRI sequences. And they should be this sort of thickness, not much more than this. Sometimes you don't see it all in one slice, and you have to sort of mentally look at two adjacent slices and make yourself confirm to yourself that it is actually intact rather than torn. If it's torn and the space is widened, that's a high ankle sprain or tibiofibular synchondrosis disruption. Okay, so here we've got an example of a normal anterior and a normal posterior talar fibular ligament. The posterior ligaments on both sides, medial and lateral, can contain a bit of fat in them. So you may see some higher signal within them, and it could still be normal. This anterior ligament is normal thickness. In this case on the right, it's showing you some thickening here and then some irregularity and thinning more distally. So that's a chronic tear which has healed. And you can see it's also a little bit gray rather than black. So that's a healed tear of the anterior talar fibular ligament. The calcaneofibular ligament here on the left-hand side is a normal one underneath the peroneal tendon, just there underneath it on the axial image. And here you've got a much thicker, harder to see because there's fibrosis scarring all around it. Two peroneal tendons going superficial to it, but this is a thickened calcaneofibular ligament due to previous injury. Then turning to the medial side, this is more of a sheet, the deltoid ligament, but on MRI, we sort of separate it into three components: the anterior, the posterior tibiotalar ligaments, and the tibiocalcaneal ligament in the middle. So coronal images, here's the posterior tibiotalar ligament, and again, you've got some fat within it, so that's normal in appearance. But here, it's all gray, it's markedly thickened. You can't see individual fibers like you can on the normal side, and that's a chronically injured posterior tibiotalar ligament. Okay, I'm going to go on to looking at the joints next. And looking at the ankle joint itself, the coronal images are really pretty good at showing you the joint space. You can see here in the fat suppressed image some nice fluid. And here's a T2 image, but you can see here there's something going on. There's an irregularity of the overlying hyaline cartilage. The hyaline cartilage is a nice little thin gray rim on most image sequences, on the T2 anyway. The T1, it merges with fluid. It's all the same signal, so it's harder to separate. And on this fat suppressed image, you can see bone bruising within the superolateral corner of the talus as well. And the hyaline cartilage, there seems to be a little defect there. It's irregular in surface. So that's a osteochondral injury of the talus. Can sometimes be very non-specific symptoms, but MRI is pretty darn good at finding them. And sometimes you'll find it when you're not really expecting it. And this is an example of a posterior subtalar joint abnormality. There's fluid, so there's joint effusion. There's marrow edema on both sides of the joint. There's some cystic change or some erosive change here in the calcaneum. And the joint space doesn't look at all normal on this coronal image. And this patient had, so in the fusion, you can see synovitis. So this is a rheumatoid arthritis example of there's probably some rheumatoid arthritis affecting the talonavicular joint also, and there may be increased fluid in the ankle joint also. This is a condition called, you can get anterior and posterior impingement, which can be bony or it can be soft tissue. Particularly posteriorly, it may be soft tissue that's causing the impingement. So here the posterior tibia may be impinging on this plica or synovial fold, which is thickened and abnormal looking. And then in plantar flexion, you can get pain here at the posterior side of the ankle joint. You may get osteophytosis or degenerative change both anterior and posteriorly also, which could cause the impingement. Okay, looking at the bones, I mean, usually fractures will show up on other imaging. Plain X-rays is your mainstay, but sometimes something like a stress fracture may not be very visible at all on a plain X-ray. So this is a T1 weighted image of the hindfoot. Here's the calcaneum, and you see this low signal, slightly irregular line going through the calcaneum. And that's a stress fracture. And if you look at it on the fat suppressed images, there's probably be edema around that fracture, which will highlight it for you. So stress fracture, this patient may have landed on the heel after a jump, or maybe osteoporotic. There may be something else going on. This condition, you can see this rather spotty, patchy, increased signal on these fat suppressed images, and it's affecting all the bones. Look, there's calcaneum, talus, tibia, and in the midfoot also you've got some of this patchy, diffuse marrow edema. There's, there's very few differentials for this sort of appearance if it's involving most of the hindfoot. You may see some overlying soft tissue edema as well, and clinically, the patient is complaining of severe pain in the ankle and foot. There may be rather white, swollen skin, and it all looks very tense. And this is a complex regional pain syndrome. If you're looking for a more modern name, if you're my vintage, then you might know it as reflex sympathetic dystrophy. And this is a condition. It's because of parasympathetic system injury, more proximal to this area. So it could be due to a fracture or an injury in the lower leg, or even more proximally, and I have seen this occur in a patient who's had a lumbar spine injury some time previously and presented with this in the foot. You may see other bony abnormalities such as coalitions, and there's all sorts of complex coalitions you get in the hindfoot. But this one is shown pretty beautifully. There's a complete coalition of the talus. Well, there's a beautiful bony coalition of the talus and the calcaneum here on the medial side. Sometimes it's a fibrous coalition, so you can still see that they're separate bones, but there's fibrous tissue sort of fusing them together. And in that sort of condition, they may have symptoms, and you may see marrow edema on both of these, bony or fibrous, but you may see marrow edema showing you where the stress reactions are because of abnormal mechanics. Okay, just going on to some other conditions of the hind foot. So here is on an axial image on the left and a coronal image on the right, fat suppressed images. You're seeing some cysts on the medial side of the calcaneum and talus. And this is in the tarsal tunnel. It's deep to the flexor retinaculum and superficial to the talus and calcaneum, these cysts. So the tibial nerve goes through that area and its branches, and you can get pain because of nerve impingement. And this may give you denervation edema in the muscles that are supplied by any nerves that are impinged on. So here, this is a normal muscle appearance on fat suppressed images. So that muscle is normal, that muscle is normal, but this one here and this one here are showing edema. And then on the actual image, here's a muscle showing edema compared to that deeper muscle there. And there it is on a more inferior slice compared to this normal muscle here. So that's muscle denervation because it's being pinched by the cysts. And in acute denervation, you can get edema in the muscle. So this is denervation edema, and it's telling us, if we go back to our anatomy books, exactly which nerve is involved and where. Sinus tarsi syndrome, so contains fat, ligaments, and a few blood vessels, and you can get inflammatory change, edema in there. So a lot of high signal on the fat suppressed image, less obvious on the T2 coronal and SAG, but it's edematous and it's abnormal looking. And the commonest cause of this is an inversion injury. 70% of these are caused by that. But you can get some inflammatory conditions such as rheumatoid, which also do this. And again, the symptoms can be quite non-specific, and then the MRI is really very helpful in telling you where the problem is. Okay, so open to questions.